Right. So um, the stomach is more or less the dilated part of the gastrointestinal system. Even when we go back to the embryology, we describe it as um, appearing as a fusiform dilatation of the foregut in the fourth week. So basically, we have a dilated part of your gastrointestinal system, which is the stomach. Content-wise, you know the physiology. It's made up of four parts. There is the end where the esophagus joins here, which is the cardia. There is the end that projects above the surface, where the esophagus goes, which is the fundus. So a fundus is a projection above a surface. You find a fundus in the uterus as well. Then this is the body. Then we have what we call the pylorus towards where the duodenum starts. So cardia, fundus, body. Then you talk about the pylorus, right? This stomach has a capacity of about 1.5 liters. And you know its function, it's involved in storing food. It also mixes the food with gastric secretions, your acid, and other enzymes, because there's also digestion happening in the stomach through gastric lipase, pepsinogen, just to mention a few. Right? Then you create a semi-solid mixture, which you call chyme, CHYME, right? Then when you look at the stomach, it has this that we call a lesser curvature. Then it has a greater curvature. Right? So there's a lesser curvature, then there's a greater curvature. When we do the embryology, you're going to find that the greater curvature, the growth of the greater curvature outgrows that of the lesser curvature, hence the difference in those lengths, right? And in an intact body, the lesser curvature, there is an omentum that attaches there. So before I talk about that, what is an omentum? So omenta are double layered folds of peritoneum that connect the stomach to other visceral organs. So it's a double layered fold of peritoneum that connects the stomach to another organ. So on the lesser curvature, I have something called lesser omentum. The lesser omentum connects the lesser curvature of the stomach to the porta hepatis. Hepatic means liver. Porta, it's a port of entry. So the part where things enter the liver. So the lesser omentum connects the lesser curvature of your stomach to the porta hepatis, as well as something that we're going to call the fissure for the ligamentum venosum. I'll show you that when we do the liver. So stomach, basically, there is lesser curvature with a lesser omentum. There is greater curvature with a greater omentum. The greater omentum connects the greater curvature of the stomach to the transverse colon. Transverse colon is part of the large intestines. I'll show you that when we get there. Specifically, it attaches onto the lower border of that transverse colon. So there's a lesser curvature and there's a greater curvature. On the lesser curvature, there is a lesser omentum that connects it to the liver. On the greater curvature, there is a greater omentum that connects it to the transverse colon. More importantly, right, the greater omentum is very, very important because it acts as a policeman of the abdomen. By policeman, what do I mean? It is quite extensive to a point that there's a picture that I usually find. It's quite extensive to the point that it can it can cover, so this is the greater omentum here. It can cover or it can follow any infection in the abdomen and plug it. So we're calling it a policeman because if it plugs an infection, it localizes the infection. It prevents the onset of what we call peritonitis, which is inflammation of the peritoneum, which is very, very painful. Presents with a characteristic form of pain that they have. Right? Then still on general features of the stomach. The stomach has an anterior surface, which is this one, then a posterior surface at the back, right? So knowing the stomach may not be that important, but knowing its relations, because in as much as you can say that somebody has a perforated ulcer, say in the stomach, that ulcer perforates and it goes to meet something, either anterior or posterior. So what do we have anterior to the stomach? There is the liver. So when I'm going to do liver with you, that means when you look at things behind the liver, you start to think about the stomach. So you need to be able to visualize things in 3D. Then again, I remember when I was still learning this, I never really liked pictures, but I liked the cadaver. Why? Because you see things make sense. But when you don't have access to a proper cadaver, you can then like the pictures. Here's our stomach, right? Here's the liver, right? So the liver is an anterior relation, right? What else do we have anterior to the stomach? Obviously, there is the anterior abdominal wall, right? Do you think the left lung and the left pleura are anterior to the stomach? Of course, the diaphragm is there as well. Do you think? Yeah.
Left lung and the left pleura.
Yes. Do you think they're anterior in relation to the stomach?
No.
So yes, they are.
Yes, 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 yes.
So when you did thorax, may not be the one who may have taken you guys for lung or whatever. Oh, yeah, but I'm sure I did. The lower border of the lung, remember, it cuts through the sixth rib, mid clavicular, eighth rib, mid axillary, then 10th rib posteriorly. When you look at the stomach, it's actually undercover of some of those ribs, right? So even when you look at the liver extends all the way to the upper border of the fifth rib. So these things are really dependent on the movements of the diaphragm, because the diaphragm is what separates the thorax above from the abdomen below. Right? Then things that are behind that stomach. There's a mnemonic that we normally use. It goes like, let's try to kick. My words are not gonna fit here. 6, 7 stones per day. These are the things that are behind the stomach. The first L is the lesser sec. The T is the transverse colon. The T is the mesentery of that transverse colon that we call transverse mesocolon. The K is the kidney, which is the left kidney. The S, the first S there is the spleen. The other S is the splenic artery. Wait a minute. Then the other S is the left suprarenal gland, commonly known as the adrenal gland. Then the P there is the pancreas. The D get me right. The D there is the diaphragm. So the diaphragm is both an anterior and a posterior relation of the stomach. So the diaphragm acts both. So the diaphragm acts. So you find it anterior, you find it posterior as well. Right. You look at this very informative picture here. This is your stomach, right? Already you can see that this is the transverse colon. This is the spleen, right? This is the pancreas. And some of the things that we were saying are actually posterior. We can see them from this kind of a view, right? Okay. Then other things that the fundus here is dome shaped. I think you can see that it looks like a dome, right? And normally common sense will tell you that if food enters through the cardia here, gravity won't put it there, the fundus. So fundus usually has gas, right? Then this lesser curvature, can you see where it ends here? Where there's a small angle. That's what we call the angular incisor. I don't know how to pronounce it. Or we can just say angular incisure, but that's not how we properly call it. It's incisura angularis. This angle here. Right? That's where the body ends. So lesser curvature, yes, it ends at the angular incisure there, but this body extends all the way to the angle, to that angle there, such that beyond the angle, all of this is now called pylorus. Remember I said the stomach is a cardia, a fundus, a body, and a pylorus. Right. Then, yes.
Can I ask you, say the fundus with the gas?
Yeah, gas.
You say what?
Gas, GAS.
What is it? Does it have something? What which gas is that?
Nah, not really. So remember we do have gas in the abdomen when people then release whatever. So this can be as a result. So this can be as a result of bacteria, for example. They can ferment whatever food is there. Then the byproduct can be gas. And for example, we can talk about these. Sorry, I can't hear you.
Okay, I'm listening.
Oh, yes. For example, there is H. pylori, a common bacteria that you can have in the stomach that can result in gas production. But that's more physiology. I'm not that qualified to talk about that, but it's there. Right.
Okay.
Okay. Then so remember, stomach is connecting esophagus above to duodenum below, and stomach really is more or less a site for regulation. So there has to be a sphincter that regulates entry and exit of things from the stomach. And in general, we divide sphincters into two. So not only two, but for the purposes of simpler teaching, there's an anatomic sphincter, then there's a pyloric sphincter. No, not pyloric, rather, physiologic sphincter. Yeah, we want to talk about pyloric sphincter. So an anatomic sphincter is, let me show you this. When I have a lumen like this, so there is diagram A, then there is diagram B. So when I have an anatomic sphincter, when I look at this lumen for diagram A, there is this. And that towards that point there is narrowing of the space that allows things to pass through. I see it. If I take a cross section of whatever part, I see it. But when it's a physiologic sphincter, it's like diagram B there. I know there's a sphincter. But When I take a section, it looks normal. The lumen looks normal. It's open. But what then happens with physiologic sphincters is they respond to hormones. For example, there is what we call, for example, this part here, between the esophagus and the cardia, there is a physiologic sphincter which responds to hormones like gastrin, CCK, secretin, cholecystokinin. You do those things in physiology. That's a physiologic sphincter. But look here at the pylorus there. Look at how there is actually some sphincter there, which you can see by the naked eye. That's an anatomic sphincter. But when you're anatomic, it doesn't mean you cannot be physiologic as well. So there can be an anatomic sphincter that can also respond to hormones. Right. So there's the pyloric orifice guarded by an anatomic sphincter. Then there's the cardiac orifice guided by a physiologic sphincter. Right. I'm trying to do it bit by bit. The histology would do, but when you look at the mucosa of an empty stomach, the mucosa of an empty stomach is thrown into these folds of that we call rugae. So there are folds of both submucosa and mucosa, and they are not permanent. It's a bit different from the rugae that we find in the bladder. These are not permanent. So why do I need rugae? The stomach needs to be able to adapt itself to the contents. So imagine someone who eats a lot, right? If you eat a lot, that means your stomach capacity needs to increase. So when you have folds, if I start to stretch it, those folds are now straightening and I'm increasing the surface area, hence I'm increasing the volume or the capacity of the stomach. So for a full stomach, the rugae will flatten and disappear to increase capacity, right? Okay. Then I'll take you back to another picture that I like. Usually that picture summarizes basically the entire abdomen. So this is the greater omentum here, one that I was talking about. Then you can see how it acts like a policeman. It actually is described as it hangs downward like an apron. Right. Okay, I don't know, I'm going a bit far. Where's the picture? Yeah, this one. So I've used this picture before to describe the blood supply of the whole abdomen. Right? I'm sure there's a video I'll share. This is a stomach here. Right. So let me give you a preview, right, of what's really happening. So we had an aorta that is ascending from the heart. Then we had an arc sent branches to the upper body. Then we had a descending thoracic aorta, which supplied some parts of the thorax, including intercostal spaces. That aorta would pass through the aortic opening in the diaphragm, right? And through the aortic opening in the diaphragm, it would then enter the abdomen to become the abdominal aorta, right? So get me right. Abdominal aorta is not simply there for organs that are there for digestion. So we divide it like this. It is 3 branches. So it is 3 unpaired. Or maybe no, let me type this out to make it a bit neat. My handwriting is bad. So it is 3 unpaired visceral branches. Then it is 3 paired. No, this visceral branches should be 3 unpaired anterior visceral branches. That's why I need to increase the size of this thing. Branches. So there's 3 unpaired anterior visceral branches. By anterior, I mean they come off the anterior surface of the artery. Then it has 3 paired lateral visceral branches. By 3 paired lateral, I mean there's a left and a right. So the first 3, there is no left and right. There's only one because there's no left and right stomach. So those that I put at the top are the ones that serve organs to do with digestion. There's one liver. There's one duodenum, right? So I don't need a left and a right. But there's 3 paired lateral visceral branches. For example, I'm going to see the renal arteries for the kidneys. There are 2 kidneys. I'm going to see testicular artery for the 2 testes. There are 2 testes, eh? Right. Then there are 5 abdominal wall branches. These ones, I know we say 5, but of the 5, 4 are called 4 lumbar arteries. I'm left with the 5th one. So 4 lumbar arteries and an artery called inferior phrenic artery. Right. Then it has terminal branches. Books will say 2 terminal branches, but there are 3. Right. There are 3 terminal branches where it terminates into right common iliac and left common iliac. That's what the books will tell you. But there's another artery that comes off the center, which we call the median sacral artery. That median sacral artery, for the purposes of pelvis, it will also supply the bladder for females. Because females don't really have some of the vesical arteries, they are replaced by the vaginal artery. So you need extra blood for the bladder. Right. So there are 3 terminal branches. Right. So after having this kind of a picture, is that a question?
Yes, I want to ask, you say the first pair supplies the kidneys, the other one the testes, then the other one supplies what?
So you said the first what?
You say there are 3 pairs, right? 3 lateral
Oh, you
visceral
mean
branches.
okay. You want me to go over that? So the 3 paired lateral visceral branches, one is for the kidney, that's renal artery. One is for the testes. For females, we say ovary. So that's testicular artery or ovarian. Then the third one is for the suprarenal gland. So just call it suprarenal artery. But to be more specific, we call it the middle suprarenal artery. Because you find that suprarenal gland has 3 arteries supplying it. So the middle one is the one that comes off the aorta.
Okay, thank you.
So the 3 anterior visceral, well, this is still here. No, I don't want this. Okay. All right. So the 3 anterior visceral branches, one of them is called the celiac trunk. It's given off opposite T12. That's thoracic vertebra number 12. That's for the foregut. So anything that embryologically is part of the foregut will be supplied by the celiac trunk. And the stomach is one of those. Then the superior mesenteric, we'll talk about it with the intestines in the second session. That's midgut. Inferior mesenteric around L3, or if you want to be fancy, about 3.8 centimeters above this bifurcation here. That's for the hindgut. Right. So celiac trunk is foregut. Why is it a trunk? It's a trunk because it gives rise to other branches. So it's just a trunk that then divides. It divides into 3. And the 3, obviously, it's going to be like this, like my fingers there. There's going to be a small one. There's going to be an intermediate one. Then there's going to be a very big one. Right. The smallest, we call it the left gastric artery. The largest, we call it the splenic artery. And then the intermediate one, it's called common hepatic artery. So let's start with the smallest. The smallest is the left gastric. I remember the other time I did esophagus and a bit of the stomach thing. Esophagus has 3 parts. There's a cervical part in the neck, there's a thoracic part in the thorax, then there's an abdominal part. Besides the fact of wanting us to divide into upper third, middle third, lower third, those different thirds have a different blood supply. The blood supply to the lower third of the esophagus, which happens to include the abdominal part, is from the left gastric artery. So left gastric artery will supply the lower third of the esophagus plus the upper half of the lesser curvature. Right. So upper half of the lesser curvature is left gastric. So common sense should say, if I'm saying left gastric is upper half, that means right gastric is lower half. Done and dusted. Right? So upper half, left gastric, lower half, right gastric. I'll tell you shortly where right gastric comes from. When I go to the greater curvature, still the same. I know this atlas is written gastro-omental, but I would want you to call them gastroepiploic. So upper half, there is left gastroepiploic. Lower half, there is right gastroepiploic. So already you know that for your curvatures, the left vessels are upper half. The right vessels are lower half. Then for the fundus is supplied by arteries that we call short gastric arteries. They are usually 5 to 6 in number. Right? So let's talk about where they come from. So splenic artery was a branch of celiac trunk. From its name, it's going to the spleen, obviously. But before the splenic artery enters the spleen, it will give branches to the pancreas, which we are not talking about for now, we'll skip. Then it gives us branches for the stomach. The branches for the stomach include the 5 to 6 short gastric arteries, and it also gives us the left gastro-omental artery, which I called left gastroepiploic. Right? And for these arteries to reach the stomach, they move in a they move in a ligament, or whatever omentum, which you may call it, that connects the spleen to the stomach. So sometimes peritoneal folds allow for arteries to move and reach organs. Right? So we call it the gastrosplenic omentum. Gastro means stomach, splenic means spleen. So we have a gastrosplenic omentum in which we find the short gastric arteries as well as your left gastroepiploic arteries. Right. Then a right gastric artery is a branch of that intermediate artery that I talked about in terms of size. That artery is called common hepatic. Hepatic means it's going to the liver. So it's still common because it's still supplying other organs. After it supplies all the other organs and it's now only going to the liver, it changes name to become hepatic artery proper. Proper meaning it's the proper artery for the liver and the liver alone. But before it does that, it's a common hepatic artery. And it will give us an artery called right gastric, which supplies the lower part of the lesser curvature. Then it also gives us a very important artery that I'll talk about that goes behind the first part of the duodenum. Quite important for people with acids. It does kill. I had a friend who died from this. It's called gastroduodenal artery. Gastro means it goes to the stomach. Duodenal, it means it will give us a branch for the duodenum as well. But besides supplying the duodenum, it also supplies the pancreas. Right? So gastroduodenal is the one that would then give us right gastroepiploic. Right? And your blood supply for the stomach is done and dusted. So left gastric, right gastric, that's the lesser curvature. Left gastroepiploic, right gastroepiploic, greater curvature. Short gastric arteries, fundus of the stomach, right? And then the stomach is so the veins will follow the arteries. So you have similar veins, right? Just that there is no vein called aortic vein. So yes, the arteries are coming from the aorta, but the veins need to find somewhere to go. And I'll introduce something called the portal circulation when we do the intestines. But for now, just remember that the gastric veins, meaning the left gastric and the right gastric, they drain directly to the liver. They don't need any other channel. They just go straight to the liver. That's why when people get liver cirrhosis, one of the first things that happens to them is they vomit blood. Why? Because blood moves from high pressure to low pressure. So when you get liver cirrhosis, there is fibrosis. The liver becomes a high pressure zone. So blood in the left gastric veins, remember left gastric artery was for lower third of the esophagus as well. So blood in the left gastric veins cannot go to the liver. So the veins will remain with the blood and they dilate. Then you are going to cough. What's going to happen? The veins will rupture. When they rupture, what's going to happen? You start to ooze the blood. Right? That's a story for another day. So the gastric veins go straight to the hepatic portal vein. Then the short gastric veins and the left gastroepiploic veins, they will join the splenic vein because they were coming from because the corresponding arteries came from the splenic artery. Then what's the other one? Oh, the right gastroepiploic will join a vein for the midgut that will call superior mesenteric. Right. Lymph drainage. If you know the blood supply, you know the lymph drainage. You don't need to read it. What do I mean? If I say this part is supplied by left gastric artery, it means the lymph drainage there is the left gastric node. If left gastric artery came from celiac trunk or celiac artery, it means left gastric node will drain to celiac node. So it's just knowing your blood supply for the abdomen. It summarizes your lymphatic drainage for the abdomen. Right. So that part is done. You don't need to really, nerve supply. This is an organ. So nerve supply to the stomach is going to be autonomic. There's going to be sympathetic, and there's going to be parasympathetic. Lazy people will just say that the parasympathetic of the thorax, the foregut, and the midgut is from the vagus nerve, cranial nerve number 10. So parasympathetic for the thorax, the foregut, the midgut. It will change for the hindgut. But for the foregut and the midgut, it remains the vagus nerve. But when we are in the abdomen, due to the embryology, we no longer have a left and a right vagus nerve rather. We now call them anterior and posterior because of the rotation of the stomach. It rotates those nerves. One will be anterior, one will be posterior. So they'll no longer be called left and right. Right. Then between those two, the posterior vagal nerve is the one that mainly supplies the stomach. Right. Then the anterior one is mostly for the liver, but both will supply the stomach. Right. Then the sympathetic who comes via nerves that we call splanchnic nerves. I'll talk about them when we do the intestines. So you get to know more about them. Then clinicals associated with the stomach. You can have gastric pain. Very quite common. So you need to understand gastric pain. You can talk about gastric CAs. You can get cancers in the stomach. You can get benign ones, gastrinomas. You can also get to know about those ones. Then you can also get gastric ulcers or even stomach, an increase in acids. But peptic ulcer disease is more common in the duodenum than the stomach. People have some tendency to think that ulcers are mostly for the stomach, but they're actually 4 times more common in the duodenum than they are in the stomach, right? So that just sums up the stomach.